exactly. I'm like, less is
Yeah, exactly.
Yeah.
So much information. You can take a sliver of it.
I know, that is how, like, I sent it out to the teams, and I'm like, I'm like really not confident I'm going to do anything with this. It's just too much.
Who knows? Maybe in like 2 years.
Exactly.
Good. She's on a maternity leave this year.
I didn't know
I know.
that.
Maybe that's why you haven't seen her.
Oh my God, I had no idea.
She had a little girl. First? Yep, first. Little girl named Olivia.
Olivia, what a name.
All right, good afternoon, everyone. Welcome, and thank you for being here for this last Advisory Council meeting of 2019. Can't believe this year went by so quickly. Thank you for being here today on this frigid November day. It is really cold out. So thank you all for traveling and being here for this hopefully great conversation today. I'm David Seltz, the Executive Director of the Health Policy Commission. Before we get going, I think I just want to go around again and just introduce ourselves for each other and for all of the people who are watching online. I'm sure everyone in the state and in the country are watching this live stream right now. There's nothing else that they would be watching. But nonetheless, reminder on the microphones, green means go. Just leave them on and push them out of your way. Don't try to turn them off and on. So, Diane?
Diane Anderson, Lawrence General Hospital.
Steve Walsh, Massachusetts Health and Hospital Association.
Bonnie Goldsmith, Emerson Hospital.
Mike Caljo from Blue Cross.
Cheryl Pascucci, Bay State Franklin.
Jim Hunt, Mass League of Community Health Centers.
Abby Selnicker, Third Rock Ventures.
Monica Sani from Mass Health.
Audrey Gasteyer from the Health Connector.
Lisa Gorgoni, Mass Home Care.
I'm pretty sure my mom watches. Hi, Mom. Rich Buckley, AstraZeneca.
Rich, you need to be over on this side.
My name is Michael Rubenstein. I'm subbing for Bonnie Gilbert for the Greater Boston Interfaith Organization.
David Mattiotto, Mass Association Behavioral Health Systems.
Donna Mosh, Massachusetts Association for Mental Health.
John Hurst, Retailers Association of Massachusetts.
J.D. Cheslop from the Massachusetts Business Roundtable.
Laura Pellegrini, the Massachusetts Association of Health Plans.
Chris Carlozzi, NFIB.
Joe Healy, subbing for Roberta Herman, Group Insurance Commission.
Great, thank you. We have all the business groups and the insurance plans sitting together here. I don't know if you did that on purpose. Very aligned. And Marcy just joined us from Atreus. Hi, Marcy. So for today's meeting, really have just two agenda items to guide our discussion today. So one, do want to take probably the majority of the meeting for some continued reflections after this year's cost trends hearings. We had, I thought, a really great 2 days. I have some thoughts and reflections on the 2 days, but interested in hearing from all of you as well. We had great attendance among the advisory council members. Thank you so much for those of you who came for part of the or all of the 2 days. For those of you who testified at the hearings, And so for those of you who weren't there, we do have a couple of summary slides and key takeaways to help kind of guide some of the reflections. But I just think it's a great opportunity coming off of that incredible 2-day discussion to then re-engage really with this advisory council to talk about your key takeaways, your reflections, and where we go next. It's a great launching pad for the next year in terms of our agenda and where we can find those opportunities to work together. So that will be the bulk of our meeting discussion today. The second part of the meeting do want to return to a new investment program that we are hoping to put up a request for proposals before the end of the calendar year. This is called Moving Massachusetts Upstream, or MassUp. And really around an opportunity to have health systems partner with community organizations and with their communities to really make impactful changes upstream in terms of the social determinants of health. And so as we've continued to think about this grant opportunity and investment opportunity, it's a different grant opportunity than many of our traditional awards, and I think we're striving for something unique and transformational, and so do want to get your input as we continue to make final design decisions, given all of your experience and expertise and what it takes to actually build partnerships and coalitions and get work done across sectors. Before we dive into the cost trends hearings, though, do want to just give a quick update on some upcoming meetings and publications, because some of this happened quite recently. So just as an FYI, we are having a full board meeting next Wednesday. We'll be here from 8 o'clock until approximately 11 o'clock. This was a new board meeting that we had added onto the schedule. So from 8 o'clock to 9 o'clock, we do expect to be in a closed executive session. And at 9 o'clock, we'll return for the public meeting. So if you're interested, or your organizations are interested in attending the meeting, you can come at 8 o'clock to see us vote to go into executive session, but the full meeting, the public meeting, will begin at 9 o'clock. And the big agenda item that we want to be able to move forward with some urgency is a proposed regulation around our new pharmaceutical pricing review authority that was included in the state budget this year. And so this will be a proposed regulation. Will go out for public comment if the board so approves it. And we are likely to have, while we don't have a final date right now, likely to have a public hearing in mid-December on that regulation, and then hope to finalize the regulation early in 2020. I think, as many of you are aware, this is a new authority for the HPC that was part of the governor's original budget proposal, and a compromised version was in the final state budget. It's a process by which MassHealth can refer certain manufacturers to the Health Policy Commission if they're unsuccessful in being able to negotiate supplemental rebates, and that the HPC that then can conduct a review of the drug and the manufacturer and actually potentially make a determination that the pricing of that drug is unreasonable or excessive. And so the regulation is really, the proposed regulation, as you'll see, is really intended to try to fill out a little bit more of the details of that process, some of the key definitions. I would say we really want this advisory council and the entire stakeholder community in Massachusetts to be able to weigh in on this regulation. We think this is really important new authority, and it's important that we get it right. And so expect that the proposed regulation will be very much a proposed regulation intended for feedback and comment. So don't have much more to share with you at this particular time, but post the meeting, if the board votes to advance, I'll be sure to circulate that and make sure everyone has an opportunity to weigh in on that process. We're also going to have some new research presentation, as well as some continued evaluation results from our CHART investment program. You can see a couple of our upcoming publications that we expect to have done before the end of the calendar year. I think most notably there is the prescription drug coupon study that we've been working on for most of this calendar year, and do expect to have that out before the end of the year. So just a couple of kind of process and meeting updates. Any questions on any of that? Great. Seeing none, we can move into a recap of the cost trends hearings. So first I wanted to share just a few of my reflections on the hearings. As always, just a tremendous engagement by the healthcare stakeholder community here in Massachusetts, as well as our elected officials. So pleased to have the governor, the speaker, the Senate president, and the attorney general all there giving remarks. Many of you were there as well. And you know, I think it was, it felt maybe a little bit different this year in terms of some of the dialogue and the conversation. I think, you know, interestingly, at the very beginning of the hearings, Secretary Mary Lou Sutters challenged the panelists throughout the conversation to keep a focus on patients. And she really asked the panelists think about their answers and their perspectives and their role in the healthcare system as it relates to the consumers of care, the patients of care. And I think for the most part, I think panelists really took on that challenge. I think there was, throughout the 2 days, I think panelists and the different panels demonstrated a sincere commitment to working towards improving patient care, and yet reflecting on some of the challenges that are inherent in our healthcare system and inherent both nationally and in Massachusetts. But that commitment to patients, I think, was something that I felt did kind of come through along the way. But there was, I think, also some wrestling with some big questions. And I think that can be a good thing. I think that part of the goal of the cost trends hearings is sometimes to reflect the fact that these are really difficult questions about how to move our healthcare system forward. And then sometimes we may not have clear consensus. But I think it's a good ability, when framed positively, to have that be an opportunity to acknowledge that there are differences in perspectives, and then hopefully be able to catalyze action coming out of it. I think there was Dr. Joe Frolkes, who was the head of NEQA, said on day 2, when reflecting also on, I think, on the affordability challenges and access challenges that patients feel, that we're aware of the looming, we're aware of the diagnosis, we're aware of the looming prognosis, but we haven't quite figured out what the treatment is. And I think that was, you know, a statement that definitely felt its way throughout the hearings. What is the treatment that we're all searching for? And I think these are big questions. What do we expect in terms of the pace of change? How quickly should we expect to be able to achieve the goals that are set forth in Chapter 224 and beyond, in terms of being able to reduce healthcare cost growth, to be able to get affordability down for patients, premiums stabilized? How quickly can we expect that type of change? What is the scale of the type of change that we're working towards? Is this incremental change, or is this transformative change? And then finally, what do we want to drive that change? Is it the healthcare market that primarily is the driver of the types of positive transformational changes that we're looking for? Is it innovation, either innovation in the form of new care models or new treatments? Innovation in the form of new technology? Do we expect technology to really be able to drive the change that we're looking for? Does the change drive from employers and from patients and from the consumers who are actually paying the lion's share of the cost of healthcare? Or is it from government? And, you know, had reflections obviously from the governor, who, you know, days before had set forth, I think, a very bold bill and an approach for setting new goals for Massachusetts in terms of increasing the amount of spend on primary care and behavioral health care. We also heard from representatives from Rhode Island who talked about how they had set goals to shift more funding to primary care. And I guess for me, my reflection is all of the above, I guess. I do still, I think, personally believe in the power of collaborative and collective aligned action across all of those different stakeholders, all reflected in this room. That includes a public and private partnership and a commitment, but that at the same time keeps its focus on patients and on affordability of care and the quality of care. And so I came out of the hearings feeling not discouraged, but actually inspired by the platform and the foundation that we have here in Massachusetts, that we can come together, sometimes disagree with hopefully not being disagreeable, and work together to try to see the type of change that we want to have happen. So I am looking forward to hearing your reflections from the hearing, but also looking forward to using this as an opportunity today and in the future to say, where are those areas, where are those great opportunities that we can collectively work together on and make real progress for the residents of the Commonwealth. So that was a monologue from Seltz. So getting into some of the key takeaways in hearing. So I want to go kind of just panel by panel through these two, and I'll give a couple of key takeaways that we had identified as staff and had written up in notes. But I think we'll pause after each panel and want to get feedback or thoughts from other members or who were there, or if you weren't there, feel free to kind of weigh in on areas where we think we can go next. So the first panel was around confronting complexity in the healthcare system, and you can see here who was on this panel. And really this panel focused on kind of administrative complexity and complexity at a pretty broad scale. So thinking about how the healthcare system and the complexity of that system impacts not only healthcare providers and health plans, but also employers and consumers, and had a representative panel across all of those different perspectives. I think we heard loud and clear that there is a tremendous amount of complexity in our United States healthcare system that causes real challenges for providers and for patients to be able to navigate this system, that it leads to increased spending in areas, administrative areas that may not necessarily provide value. We had one of our panelists, Dr. Apkon from Tufts Medical Center, reflected that when he was the CEO of a children's hospital in Canada, their annual administrative budget was something like $1.5 million. At Tufts Medical Center, it's $50 million. So had some reflections on the differences in different types of healthcare systems. I think there was some interesting opportunity and conversations around how we could potentially use technology to help address some of these concerns, both in terms of giving great tools to patients to help them navigate the system, but also if we were able to move towards electronic prior authorization or electronic credentialing and forms, that there can be some efficiencies just in being able to use technology in new ways to reduce unnecessary administrative variation. And then I think a big broad question that was left at the end, how much of this can we do kind of working together in kind of a collaborative way? How much of this requires government rules or regulations to try to move towards some simplification? Amy, thank you for being on there representing the consumer voice. We also had Representative Cheryl Corman, who represented the employer voice and talked about how difficult it is for employers to navigate the healthcare system and buying health insurance. So I kind of came out of this panel, I think there was a great acknowledgement of the problem, and I think a really kind of deep and sophisticated conversation around the problem. Some conversations about where we could go for solutions, but I think still trying to understand where is the best opportunity for either the Health Policy Commission or the state writ large to really be able to lean in and make some big differences. So that's kind of my key takeaway. Amy, since you were on this panel and participated in the conversation, I don't know what reflections you might want to share, and then open it up to everyone here.
Thanks, David. So I guess the one thing that I think is in here, but maybe to spell it out a little clearly, and I think it wasn't just on this panel, but I think I heard it multiple times throughout the 2 days, was the importance of not trying to place too much of the burden on the consumer who is going through a crisis of some sort and sick and trying to navigate it, and that we can't rely on the consumer to have to self-educate to fix away all of the problems. And I think I think it was raised on this panel, but I was pleased to see that I felt like that came up multiple times throughout the 2 days. So maybe it's later on in here, but I just wanted to elevate it a little again.
No, I think there was conversations around what can we do for consumers, but I think also an acknowledgement, let's not kid ourselves that this is going to kind of solve all of these problems, especially in cases where, heard from you and from others on that panel, personal stories of even people who have a deep understanding of the healthcare system being really challenged to be able to get the care that they needed in the right time and the way that they needed it. Any other thoughts and reflections on administrative complexity, or where coming out of this you see opportunities for the government or HPC to continue this type of work? Laura?
So David, as you're aware, and maybe folks around the table don't know, we've been working as a collaborative with Mass Hospital Association, Mass Medical Society, and others over the past few years to try to address ways to make healthcare simpler. One of the things we've been engaged in, which was a legislative requirement, were 2-page forms for prior authorization. So we're going through a number of different treatments that might require a prior auth and developing those forms. At least at MAP, we have convened a subgroup of the board to look at some of this a little bit more deeply. And I think one of the opportunities we think does exist is around automating the prior authorization process, and the technology is emerging. There were some pilots going on around the country. So we've expressed that to our colleagues at the collaborative, but that might be a place where we could all agree to work together, where we could put that in an electronic platform and have real-time decision-making, but it requires all of us working together. We're also looking at some other things that the Med Society and others have raised, so I guess my message is MAP is very willing to engage in these conversations with everyone.
Thank you, Laura. I think certainly there was a good part of the conversation was around prior authorization and understanding that prior authorization has a role, but are there ways that either we can speed up that process so that we're not leading towards gaps in care, or to be able to kind of streamline and have some more alignment. And, one of the things that we had shown at the hearings was that there a scan of different orthopedic procedures and all of the different health plans, and the fact was that every single health plan kind of had a different set of rules, even among a set of common procedures, and maybe there's an opportunity for us to, not take everything under the sun, but maybe if we could say, okay, let's take some set of procedures and really think about what are the best practices, what are the clinical best practices, what should we be driving towards, and if there can be some agreement on that, even just having alignment among the plans, I think would help providers certainly, but also help providers be able to more easily be advocates on behalf of their patients and to know what types of rules would apply without having to know everything about that patient's health insurance plan. One thought.
One quick thought. To that end is I think it's important for Mass Health to be part of those conversations, that an all-payer solution includes government pay as well. And to that end, I know there's been some discussions on that even at the collaborative level the pain point.
I just switched to that microphone is making you sound like a monster.
Could be me. It would be helpful to add MassHealth to the conversation, essentially, so that we truly have a solution that reduces administrative complexity for providers. Because if we have a commercial solution only, I think we still run into the issues that are problematic. So that's just a quick note.
Yeah. Thank you. Any other thoughts on this panel, or I'll just keep moving? So the next panel, Joe?
So two thoughts. I think somebody observed, during this panel discussion that there's no powerful incentive. People don't compete on reducing complexity, right? And some of the complexity is created because of our reimbursement models and contractual arrangements and so forth. So I think given that it's either convening organizations, like Laura just described, or maybe this may be a place when you think that there's no sort of market force pushing, where there are market forces pushing things, they tend to happen. When there's no market force, then the default is either some sort of convening association or the government. The one piece that I think is missing, a lot of these issues are very, very challenging. There was acknowledgement that there's administrative burden at both sides of any interaction, the plan, the provider, et cetera. Both are carrying an administrative burden. I don't know if somebody's done a deeper analysis of where the administrative burden really is, what forms it takes, and as a first step, and maybe it is prior auth, I don't know, where are the places where there's big burden, it's not controversial, all it will take to make change, because some of them are very controversial and some of them are very, very challenging, but I think somebody doing that analysis could sort of tee up a piece of work.
Yeah, that's definitely been top of mind as we've been taking this project on, is both quantifying where those areas are and then trying to think about prioritizing. We did show at the hearing, we did ask, we surveyed all of you as advisory council members. We also surveyed more organizations through our pre-filed testimony process around what are their top priorities, where are their biggest pain burden areas in kind of the administration of healthcare. I think, unfortunately, there wasn't clear alignment between the provider and the payer responses. But nonetheless, we have talked about maybe low-hanging fruit in areas like credentialing, where it is not going to kind of maybe save all of the most money in the world, but is a pain point that feels like a solvable type of thing. Prior authorization, maybe areas for some improvement. And then other areas where truly the kind of bespoke nature of employer, health plan, provider, contracting is going to make it difficult to try to find those areas of alignment. So I think from the HPC standpoint, we are continuing this project. I think we are going to write up all of the research and work and kind of conversations that we've had throughout this calendar year, and hopefully be able to kind of continue to mobilize action maybe on some key priority areas. Amy?
I'll say one other thing, which is, as there's two reasons. Well, from my lens, there are two reasons for doing this. One is to make it more manageable for people to navigate the system. The second is to bring down costs. And I think as you're doing that analysis, we have to make sure that this is the decisions and what's happening. We have to make sure those are being passed along, the savings are being passed along to consumers, so that 5.6% number that is above the cost growth benchmark is actually coming down and meeting the same thresholds that the rest of the state cost benchmark is at. So.
Yep. Well said. Oh, yep.
I had to watch it online from work, but and I may have missed it. But when you're talking about relieving the hassle from the consumer, did anyone talk about the disruptors being Amazon and Walmart, and that they are going to make this cheap and easy, and that's the push? That's why it has to be quick, and we have to figure this out, is because it's coming soon to a retail shop near you.
Yeah, I think it did not come necessarily up in this panel. Interestingly, in the kind of the primary care and behavioral health care innovation panel, there was a little bit more conversation around what are some of these quote unquote kind of disruptor organizations going to be doing, and what does that mean for the kind of the traditional healthcare system, so to speak, and what happens when there's a more for-profit, capital-based system being put in place. But certainly, patients want convenience, and how can we ensure that we're working towards that? And I think a lot of conversation about technology. I think one of the other key themes that came out through the entire 2-day hearing was a broad consensus from everyone around the power of technology and telemedicine in particular, and perhaps being helping to relieve a lot of these burdens, but also give good, convenient care to patients too. If we can figure out how to leverage that technology, right? It's a big part of the governor's bill as well. So the second panel was on pharmaceutical market trends and cost drivers, and you can see our range of different participants here as well, including a provider and a Medicaid managed care organization, lead pharmacy officer, kind of a pharmaceutical market analyst, Harvard Pilgrim, and then CVS Health, which now includes both CVS Caremark, the PBM, CVS Minute Clinics, and Aetna are all kind of sit underneath CVS Health. And so I thought a really good, sophisticated conversation and nuanced conversation around some of the pharmaceutical issues. I think first and foremost, again, an acknowledgement of some of the challenge that rising prices in pharmaceutical drugs are having on all parts of the system, and that they're now an ever increasing proportion of the healthcare dollar. I think broad consensus that more transparency is needed throughout the supply chain. Yes, there a lot of the conversations focus on the manufacturers, but I think there was a lot of conversation around the need for more transparency of pharmacy benefit managers. Would note that the representative from CVS Caremark said he was open to regulation, so have that on record. And that's, I think, some conversation with the secretary and other commissioners around what is the value add of all of the different parts of the kind of supply and distribution chain, and how do we ensure that we're both being transparent about that, but also that every part is being held to some standards of accountability as well. Talked a lot about value-based contracting or outcomes-based contracting, both the kind of potential promise. Harvard Pilgrim, of course, has been a national leader in this area, but also some of the complexities and challenges that go into creating those types of relationships, the administrative complexity, measuring kind of progress in patient outcomes, and that. While certainly is a greater orientation towards value is, I think, broadly seen as a positive thing, that these types of contracts may not be appropriate for every type of drug or treatment, and so has a place in the constellation of solutions, but maybe isn't the silver bullet. A lot of conversation about rebates and how do we account for rebates and what is the history of rebates. I had to go after the hearings and look up some antitrust case from the 90s to try to understand the history of rebates. Do not recommend trying to go down that rabbit hole. And ultimately, how do we kind of get, if there are rebates or if there are savings being generated along the way, how do we ensure that patients actually share in those savings as well, that they're not, that ultimately patients aren't being the ones facing very high out-of-pocket cost burdens, while others are sharing in some of these savings arrangements. Noted that CVS does have a kind of a pass-through model where they try to share the rebates directly with patients, but that model had not been widely adopted by their employer contracts. So obviously, I think a key takeaway and a next action step is moving forward on the process that's in the state budget. Also, of course, the governor proposed expanding that authority as part of his legislation. So I think, again, a conversation around what is the role of government in terms of being able to provide greater transparency and accountability for this sector of the market, which hasn't traditionally been under the same type of scrutiny or the same type of statutory authority of the HPC, and is now kind of moving more under the umbrella of the collective state action. So any other kind of feedback, reflections, or kind of takeaways that you heard from this panel, or where you would advise that the Health Policy Commission continue to kind of push and focus as we think about the entire kind of prescription drug and innovation market?
I think I would add that just like in the last panel where we were discussing complexity and the complexity of rebates and antitrust laws, that from a consumer perspective, that challenging that complexity at a first pass and looking to see how that complexity is justified as a first principle might be something that we want to sort of lift up in the process of this examination. And I would also add in the area of technology that is also worth lifting up, because making a bad process faster doesn't necessarily help anyone. So I would lift that up as well.
Thank you.
We'd agree, right? I mean, I think on behalf of the whole industry, we've thought that the rebate system was not just complex, but opaque unnecessarily on both fronts. And so considering at the federal level rebate reform was something we lean very much into. You begin pulling on the threads of that, it has other implications that became politically untenable in other parts of the sector, but we agree. We're obviously pleased for the continuing conversation, not just about value-based contracts, but also the push and pull between the cost of a drug and the value of the drug in terms of its ability to displace other healthcare costs. So once you get down the road of HPC, maybe looking at the value of the drug, that's a conversation there, which is not just the price, but are you displacing a more expensive treatment? Are you preventing a rehospitalization that costs you money elsewhere? So we think, it's a healthy, constructive conversation.
Yeah, thanks, Rich, and definitely a panelist from Boston Medical Center reflected on thinking about these things holistically, and in terms of not just the prescription drug spend, but how that impacts and interacts with total healthcare spending and the total dollar, and sometimes the difficulty of putting those pieces together. In this particular case, it's a health system that is also a health plan, and they have a little bit more ability to see those things, see both sides of that coin, but not all organizations have that particular advantage. Marcy?
For some of the drugs, it might be worth thinking about too, who do we think should have the responsibility for the, large cost drugs that have a low rate of occurrence in the population? Because particularly as you're asking providers to take on risk, being unlucky enough to have, some number of those in your population when providers don't have reserves is not going to be a good thing. And it falls sort of indiscriminately, whereas, we probably all have that responsibility. And so thinking about how we as a state want to think about that might be, one area of opportunity.
Yeah, I think that's a great point, and certainly knowing what we know about the pipeline and in terms of what we expect for some of these new therapeutics and biologics and gene therapies that are going to be coming down the pipeline, many of which may be in the kind of the physician administered space, that may impact providers as well. And so thinking about how do we equitably kind of think about financing, that kind of the financing model was also something that came up briefly kind of in the panel.
It might be the other place to look at price regulation on the provider side, coming back to the oncology report. that you guys did showing, the price of the drug to consumers is, or to plans, is very different depending on who's administering them, even though the drug itself is the same.
Yep. Mike?
So I guess my point would be to look at lessons learned from even the actions that we're putting in place on November 20th from the conversation around MassHealth pharmaceutical structures, because I think a lot of the open questions about role and responsibility and level of regulation are directly related to the structures that you would put in place from a regulatory regimen standpoint. And I think there are different paths that folks could go in any number of different ways. And as we move from MassHealth specific focus to commercial wide focus or all payer focus, I think there's some interesting questions that we need to answer in terms of levels of acuity. How much and where do we want to focus the state's attention to drive at meaningful questions on a one-state basis, right? And I can see arguments on either side of this issue. It's somewhat unusual in the sense that it's not the players are not particularly unique only to Massachusetts. That we've benefited from having really locally sourced providers and locally sourced health plans, which has helped our regulation of those two markets. And I think as we get to that level of questioning about role relative to pharmaceutical prices, for example, I think that's just a natural question that we have to grapple with.
Yeah, and beyond just some of the actors not being, headquartered here or even in this country potentially, the role of the federal government is so key and crucial too in understanding that how the market is set and some of the rules are set, and whether there might be federal changes either in regulation or potentially legislation at the same time. Amy?
I was just going to say, to echo what Mike was just saying, I do think that that is one of the things that has worked well in the Massachusetts example, is that all of the different players have come to the table, and the incentives to bring each of us, whether it's consumers, employers, others, to the table, are appropriate for who we are. And so I think that that's one of the things that we have to think about, which is like, what is the appropriate incentive that will help bring down prescription drug costs that is both fair but also put some skin in the game. So.
Joe?
David, I want to build on Dr. Sendel's comments. So I think there's probably alignment and an agreement that these very high-cost specialty drugs that are now providing treatments for people who before had very poor or no options is very important, right? We would all agree those folks need the care, they deserve the care, they should have the care. And the manufacturers take the risk of making the investments and trying to develop these drugs. And in general, in our economy, risk is proportional, profit is proportional to risk. But then I want to link this to the transparency survey that was rolled out at the State House last week and all the confusion around transparency. This is one area where I think transparency could help a lot, because you start with a very high cost drug, but then and people are focusing a lot on the PBMs right now, but there's a whole continuum. The drug goes from the manufacturer to the wholesaler to the PBM to sometimes directly to the patient, some through a pharmacy, sometimes to a provider, sometimes to a hospital. And at each step along the way, everybody's marking it up, right? They're not just taking the cost and that's what they're billing. Everybody's marking it up. So we're taking something very, very expensive that we all agree is critical for patients to have, and then in some ways, to be blunt, exploiting that opportunity. So I think looking at the markups, and I understand all organizations need, first of all, we're all dealing with these growing costs, and so we're all struggling to balance our bottom lines. But I think there may be an opportunity there if we unpack what's going on at each of those levels. The manufacturer who takes the risk deserves to be able to cover their costs and make a profit. But beyond that, nobody else took any risk. We're just marking it up, marking it up, marking it up. And I think there's an opportunity there to keep something that's going to be high cost no matter what, a little less high cost for all of us.
Yeah, I think unpacking that entire chain and having greater transparency and understanding of how much of the dollar is being used at each of those different locations along the way, and what is the value that's being provided. And I think that was, a question that still is definitely focused on PBMs now, but I think, as you said, certainly we have to think about that entire continuum, and ultimately, the person at the end of the continuum is the patient. And right now, the system sometimes leaves that patient paying off of a list price of a drug when the actual net price of that drug is something very different. I think one of the other kind of big macro themes that came out to me over the hearings was we have a healthcare system that is perfectly rational for the way that it's been designed, and yet, is that kind of the design that we want? And so when we have these rebates, yes, it creates these incentives now where the list price goes up, but then we give it away in bigger rebates, the list price goes up, more rebates, and it's all perfectly rational and makes economic theory, but ultimately it leads to this place where it's like, well, what about the customer at the end of the day? And so thinking about how you kind of, and I think the question was raised earlier, maybe starting with a basis standpoint of, is this the type of system that we want, even if we understand that it's rational and everyone is acting according to their own economic incentives and interests, and how do we actually change some of those incentives and leverage the market to do that? Great. All right. So the next panel was on day 2. And so just one quick slide on the presentation from Marie Ganem, who is the Health Insurance Commissioner in Rhode Island, and Chris Kohler, who's the CEO and president of the Milbank Foundation. I thought a really great presentation and conversation about increasing state action towards rebalancing and shifting towards a more primary care focused healthcare system, and how Rhode Island set some goals to be able to increase the proportion of healthcare dollars that was going to primary care over time. How they achieved those goals, they did. Where they spent some of that money, they really focused on non-fee-for-service payments and infrastructure payments to primary care providers to be able to use to expand the care team, to introduce new technology, to have after-hours care, and some of the great outcomes that they've had in terms of improvements in health, reductions in utilization and hospital discharges as this shift has occurred. And Chris talked about some of the different big design choices that go into such a policy in terms of what are you measuring, what are the targets that you set, where do you want those dollars to go. But nonetheless, I think was very encouraging and positive that a more primary care focused and oriented healthcare system is a worthy and laudable goal, and there's different ways to try to get there. And so that led right into our next panel, which was around strengthening primary and behavioral health care, and a great representative of panelists here as well. I think some of the key takeaways was that there has been a historical underinvestment in primary care and behavioral health care over a long period of time, and that's sometimes the market has not incentivized putting payment in those areas, and how can we think about changing those incentives or changing that market structure over time. I think a real consensus around using kind of the multidisciplinary care team, using different types of healthcare providers on the primary care team, including licensed clinical social workers, community health workers, pharmacists, and as well as peer recovery coaches and other things that can all work together, and that if primary care had more investment, that's where some areas where they'd actually think about being able to expand. We had a great panelist who is from a new startup primary care practice that is really trying to be technology-based, Firefly Health. I think one of the interesting comments that he said was when asked, how many primary care visits do you think could shift from an in-office visit to something over technology, and he said something like 75% he thought could actually move towards a more technology-based relationship. They have an interesting model. For those of you who don't know too much about it, it's different than the other telemedicine and maybe technologies. There is one, you are meeting with a doctor that is the same doctor or the same clinician, so it's not necessarily something, there is still this idea of relationship building and having a relationship. And then I think a great conversation, of course, as well on behavioral health care and the need to integrate behavioral health care into these conversations and into primary care. What are the best ways to be able to invest in these areas, and heard from in particular, Christina Severin from C3 and Dr. Nancy Norman from the Mass Behavioral Health Partnership around the potential and the promise of being able to do this, and how Mass Health and the DSRP program in particular has really helped drive some of these changes. So I think obviously the backdrop of this particular panel, I think, was influenced by the governor's bold proposal that he put out in terms of being able to increase the investment in primary care and behavioral health care. And I think there was broad support for those goals among these panelists and most panelists, again, but still a reflection of how exactly that happens and in what areas do we want to make the investments is critical and important.
Given that there's an established evidence base for the integration of behavioral health and primary care in care for adults through the collaborative care model, and a growing body of evidence on enhanced pediatric practices that integrate care, is the commission thinking about, and I know you've actually paid over the years for some services demonstrations on the integration of care, as has the Blue Cross Blue Shield Foundation and others. Now we have the Smith Family Foundation and the Klarman Foundation funding further demonstration of the enhanced pediatric primary care opportunities. Are you considering any kind of technical support or reports that could help guide the move to expand the percentage of total medical expenditure on behavioral health and primary care using these integration models?
Do you think that would be helpful?
I do.
So the short answer is yes. I think we're going to see, obviously the legislation that the governor proposed will go through a process, and what happens there is yet to be determined. But I think regardless of that legislative proposal, this is a model that we know works. And I think we are always thinking about what are the best tools that we have in our toolbox to try to continue to push the adoption of the collaborative care model, as you suggest, to be able to help primary care practices learn from each other in terms of how best to do that. So continues to be a priority for us, and it was part of our patient-centered medical home certification program, was a focus on kind of the behavioral health integration model, and always open to ideas about how best we can kind of move that forward. But obviously the governor's bill and the idea of being able to increase investment in primary care and behavioral health care begs the question of where would we want to see that investment go, and maybe an opportunity to highlight the truly best practices that we know exist in that work. Jim?
It would also be good to highlight where it shouldn't go, which is into letting people raise salaries for the purposes of poaching from each other when there are so few providers, both in primary care and behavioral health.
Said a different way. I was encouraged that the goal of the session would include workforce development, and I think it fell a little short there. And I would hope that we would refocus on workforce development. We've now coining the phrase, no workforce, no capacity. So the behavioral health incentives and the growth in payments of behavioral health is a given for us, and that's great from the perspective of encouraging the workforce we've got, but we've got to make or buy the new workforce going forward at all levels. So I would hope that, I spent so much time trying to figure out what Firefly was that I couldn't focus too much on handing questions to the panelists, but I thought it was a great panel. But I hope that we don't drop the whole issue of how we grow the workforce, particularly in primary care. It is front and center for us. So, thanks.
Thank you, Jim, and I take that challenge on as well. One small piece, just as a plug, we are going to be releasing, I think, a white paper or a policy paper, probably in the beginning of next year, around the role of nurse practitioners in particular, and how they can help expand and extend our primary care workforce, and where Massachusetts has outdated, my words, scope of practice laws that may need some reform in order to continue to be able to support that particular part of the primary care workforce. But one small piece, not saying that addresses everything that you mentioned, but continue to try to think about that whole problem. Lisa?
Yeah, I just want to also add, when you're talking about the non-clinical staff that I've been part of, and I know many people with the Healthcare Collaborative that Secretary Sutters and Secretary Costa have been working on with the non-clinical components. I think that'd be good to kind of incorporate that work into this conversation as well.
Yeah.
Some good work in that area.
That's a great plug. Thank you. So the final panel was provider market trends and cost drivers, and we had quite a distinguished group of chief executives from across the Commonwealth participating in this final panel. And I think the final panel ended up being touching on all of the themes and all of the topics from across the 2 days and beyond. And I think was intended in some ways to be kind of a wrap-up panel that really can reflect on a whole range of different interests. Definitely, part of this panel I think came back to, again, a discussion around affordability. And while we're making really notable and laudable progress in being able to hit our healthcare cost growth benchmark, even the newly revised lowered 3.1%, how are we continuing to think about the real affordability challenges that many residents of Massachusetts still face, and how can we think about keeping urgency on these efforts, patients and employers, I should say, as well. We had some conversations among the panel around interesting initiatives that each one of the different organizations was working on to try to either reduce healthcare spending by shifting care to lower cost settings, or by taking administrative costs out of their own system. But I think also reflected from some of these big major organizations that there is a lot of things that impact health and healthcare spending that they believed were outside of their control. So not only things like labor costs and pharmaceutical drugs, but also the social determinants of health that impact healthcare spending. And I think a general consensus that there continues to be a need and a way for the health systems to be able to partner with community organizations and how best to address those issues and how to best finance the investments that need to happen perhaps outside of the healthcare spending. And I think ultimately, I think there was a commitment among the panelists that they're all working on it, and that there was still a sense of let's keep at this, and try to continue to remember some of the positive areas for progress, even as there was some real challenges in terms of thinking about affordability in particular. So this one kind of touched on a lot of different areas, including also administrative complexity and other things, but this was our big wrap-up blockbuster panel. Interested in any other of your thoughts or reflections. Again, kind of where do we go next on some of these issues?
Dave? Excuse me. Did you hear, I wasn't able to stay for this panel. Did you, on the third bullet there, hear any revealing or insightful things on partnering with community organizations on the social determinants of health? That's a huge issue for behavioral health hospitals. And I'm just wondering if there were the panel gave any insightful observations there.
I think there was, I don't know that we got into the details in terms of kind of the key strategies. I think every one of the organizations, I think, reflected a commitment, David, but I think it didn't dive deeper. And not that they don't have those details, I think it just wasn't where the conversation ended up going. Audrey?
I just wanted to share, I thought this panel was great. I thought the whole hearing was really exceptionally done. And I thought it was a tough panel, so I just wanted to commend the commissioners for the toughness of questions and the seriousness of focus around cost containment. And I think coming back to the Secretary's comment earlier at the beginning of the hearings, that there was a sense that the unsustainability of costs, both to families and to businesses in the Commonwealth, is just untenable. And you could hear that in the questions that the commissioners had for the executives and that they even had of themselves. And I think in Massachusetts, where we've been such leaders in access and so many different kinds of innovation around healthcare and health policy, I just found it really refreshing that we're being so tough on ourselves about this. When you look at, a household spending $20,000 on healthcare every year, it's just not sustainable. And so just coming back to, from the Health Connectors perspective, and our 300,000 members that report constantly their challenges with affordability, even on top of the exceptional work we've done in Massachusetts to make things accessible. I just wanted to kind of connect those two dots, that it was, I think, really appreciated on behalf of the people we're trying to do this good work for, that we're not yet satisfied and we know we haven't arrived yet. So thank you to HPC for really kind of driving that tone.
Thank you. And I would say, I think a reflection and a sense of gratitude also for the panelists who I think all felt agreed that there is more work to be done, and that they're individually organization and personally committed to continuing that work. And I think left us, and I say the collective us, with a question of where we go next and how best to drive that forward. I think the governor has put forward a number of really thoughtful and promising proposals in his legislation, many of which have been recommendations of the Health Policy Commission for some time. And I think, as was stated multiple times in the hearing, an inflection point for this chapter of Chapter 224. That didn't come out quite right. But this time of Chapter 224, in a sense that maybe there is a need for modification and for improvements and enhancements, and for setting new goals for ourselves, and maybe some tougher goals for ourselves that we can collectively work on together. And what the form and shape of those finally will take, I think will play out during this next session. But I think there was still a consensus that let's continue to build on the Massachusetts model. Let's be proud of the way that we've addressed these things in the past, which is, yes, sometimes incremental change, but every once in a while, a big step forward. And so I'm excited to work with all of you on kind of helping to advise and to go to that next step, wherever that may take us. JD, did you want? Oh, sorry. You were just really into that.
Yeah, that was good.
Marcy?
I'm sorry I wasn't at the panel. Well, maybe I'm not sorry because I was on vacation in Mexico, but I was, I am sorry.
Streaming on your phone, at least?
No, I missed it. I'm sorry. One of the things that's come up from time to time that I'm wondering if came up at all on this panel, or if you've had any thoughts about, is the question of how we deal with teaching and research. You know, obviously one of the reasons that we stand out and our costs are so high is because we're fortunate to have so many academic medical centers that provide phenomenal services, not only to us but to the nation. And I know that's come up in the past. Was there any comment about that or thinking about that? And is that an area perhaps to do a deeper dive on to see how we might think about it, how other nations deal with it, and so forth?
It was not something that necessarily came up in this particular panel. It definitely has been a source of conversation before, and as we've talked about, provider price variation is always one of the key topics that comes up when we think about that particular issue. But the conversation didn't necessarily go that direction. I think a couple other takeaways. There was, I think, again, one of my commissioners asked questions about kind of some of the governor's proposals. Again, I think a strong consensus among the panelists around technology and telemedicine. Dr. Ann Klebanski from Partners talked about kind of hospital at home models and being able to bring more care to patients in that setting with the aid of technology, and how that can help reduce unnecessary utilization of the hospital setting. And so that was another theme. And then finally, I think it did end up, there was some great comments at the end from Commissioner Foley around workforce and keeping workforce in mind on all of these big policy conversations. And I think the idea of not just quote unquote physician burnout, but burnout and challenges that face every part of the kind of healthcare workforce, and how do we leverage the healthcare workforce to be a part of the solution as well. So didn't dive too deep in that particular topic, but I think was a nice button on the conversation that brought up an important issue. Steve?
Thanks, David. So I agree with Audrey that the tone of that panel was different, and I'm not sure it's a good thing. I didn't think that the tone reflected your opening comments around the positive nature that the Health Policy Commission approaches the cost trends, nor the statement about being able to disagree without being disagreeable. I thought the panel missed Commissioner Altman's levity and civility, frankly, and I thought the panel took on more of what we're seeing nationally, which is a lack of civility and discourse in discussing hard issues, and it was different than I think we've seen before. And I know the work that you and your team put into these, and you do an extraordinary job with the planning and the execution of the cost trend hearings, and I thought it ended on a dour note. Had I watched that, I would have thought we missed the benchmark. The reality is I think we missed an opportunity for a positive discussion. We had Oregon, Connecticut, Rhode Island there. In the Rhode Island presentation, they talked about how they wished they could be doing as well as Massachusetts. Oregon and Connecticut came to learn about the cost growth benchmark. If they went back to their states, I think what they would say is, yeah, it's working, but it doesn't really matter if it works, because you're going to be subjected to lack of civility and grandstanding by commissioners about what else you're doing. And so I think there is a good opportunity for a discussion in the legislature about whether the benchmark could be lower, but the reality is it isn't lower. And those panelists over 2 days had met what they were statutorily asked to do. And there's another commissioner, there was another representative on the panel who had signed an agreement with the Attorney General, and that agreement was questioned. And I think that was unfortunate, and I think it missed the opportunity to show the level of collaboration that the Health Policy Commission has become to know, to show that the benchmark was made and that we continue to move in the right direction, and to show that this is a really good story to tell, and people are coming from around the country to hear the Massachusetts story again the same way they did in 2006. And so I left a little bit saddened on the end of the second day. I thought the first 3 panels, and you and I had talked about it, things were going so incredibly well. And then the questions were, I know that there's other factors that drive the cost of healthcare, but forget about all those for a minute, and under subpoena tell us why you're taking all the money. And I just don't think that was constructive, and I found it to be unfortunate in what could have been a great story to continue to tell. Can we do better on the provider side? Absolutely. Can we lower costs? Absolutely. Can we push more to value? No doubt. But we're saving patients' lives each and every day. As the Secretary said, it's about patients. And the folks that are on that panel, it's their vocation, their mission, and their profession to save patients every day. And I thought they were not treated with the respect and deference that their positions deserve and demand. And I thought it was an unfortunate way to end what was otherwise a very informative, educational, and excellent cost trends here.
Well, thank you, Steve. I take your comments to heart, and certainly there is a balance to all of these things in terms of lauding and celebrating the progress we've made, continuing to push forward in areas where we know that we can continue to make improvement, and I guess I try to send a message of collaboration and shared responsibility and accountability for all parts of the healthcare system, and understand if you thought we missed the mark on that one. So, the risk of ending that conversation on a sour note, the challenge is moving forward. Want to be able to continue to find great opportunities for collaboration and opportunities for improvement and collective action. So I'm happy to turn now to a project that we're really excited about that is actually perfectly designed and all of these things, that is really around trying to incentivize and create that type of collaboration and across both the healthcare system, but beyond the healthcare system. And David, to your question earlier around how do we partner and address some of the really challenging issues that drive poor health, health disparities and inequities, and think about how HPC with the Department of Public Health could actually make some investments and test some pilots that we think could make a really big difference. So I'm going to turn the conversation now. We only have about 15 minutes left, but I'm going to ask our Senior Director for Healthcare Transformation and Innovation, Kelly Hall, to join me here, along with the Deputy Director, Catherine Harrison, just to give a few quick updates on the progress of this project. I think we have talked to you about this before, and we did request some feedback on our project, so we want to just spend the few remaining minutes we have with you testing some of our design considerations before we finalize this particular investment opportunity.
Thank you, Gabe. Can everyone hear me?
Yes.
Thanks, David, and thanks for the introduction. Since I am batting cleanup today and we have limited time, I'm going to buzz very quickly through some context-setting slides about MassUp, and then move on to what we're really excited about right now and is consuming a lot of our time, which is design of our investment program, so that we can enable some of the kinds of activities that David spoke about in the intro. So, what was the rationale behind MassUp? I think, the rationale has and continues to be the recognition that we are frankly not going to ever be able to get on top of issues of cost and quality and outcome if we don't recognize the social factors that influence patients' lives when they're not in the doctor's office or in a hospital. If we think about the program in general, I'm going to skip past some of the specific details of the background. The goal of MassUp is really better health, lower costs, and reduced health equities across communities and populations in Massachusetts through effective partnerships between government, healthcare systems, and communities to address the social determinants of health. So, David, that does speak very specifically to your question and the goals of the program. There are actually 4 components of MassUp, and they're all really, really important. There is an investment program that HPC will be leading, technical assistance that will be provided by the Department of Public Health, policy alignment that will involve not just the DPH, but the Attorney General's office and others. And finally, a rigorous evaluation so that we can document what we've learned and ideally spread those learnings broadly. As I said, all of that work is really important, but today we're going to focus very specifically on the investment program and what we have learned to date about how to structure it. So as I said, the purpose of the MassUp program is really to support partnerships, and that's a word that will come up again and again and again as we talk about MassUp. And those partnerships really are between healthcare delivery organizations, providers, and community-based organizations, because we believe those partnerships, and it's not, frankly, not just what we believe, but what literature tells us and experience tells us, that it's those kinds of partnerships that will be most likely to have a meaningful impact on health outcomes and cost. If we're successful in MassUp, and we are confident that we will be, what we hope we are going to achieve is internal alignment of a lot of disparate efforts. The good news is, in the spaces that we all occupy, social determinants of health and health-related social needs are getting a lot of attention. The bad news is, in many cases, that attention and that focus is real, but it's not coordinated or aligned. So we're missing opportunities to increase our impact. We're also hoping that we can initiate some new work and new investments focused further upstream. And we'll talk a little bit about exactly what we mean by that in the next slide. We're also very, very concerned about sustainability. I mean, like many of the investment programs the HPC undertakes, we have the privilege to be able to make investments and experiment, but the goal is, we can't fund everything forever. The goal is to try to learn and work from the beginning to ensure that these initiatives have legs after we're finished. So this is envisioned as a 3-year program, including a planning period. And it's funding of approximately $1.25 million from the Payment Reform Trust Fund. Right now, our thinking is that we'll allocate those dollars across 2 to 3 awardees of roughly $625,000 each. But we're going to withhold total judgment on that until we see what comes in. So let me talk a little bit. Oops, my slide's not moving here. Okay. Let me talk a little bit about what we mean when we say moving upstream, because I think when we present this material, I usually say this is the most important slide of all. And I say this particularly when we're talking to delivery organizations. It's really important to be clear. In the last several years, healthcare delivery organizations and community service providers have done some really, really important and meaningful and valuable work to connect patients with the community-based resources to address their health-related social needs. Things like, transportation services and food vouchers and the like. And I would be the last person to not say that that is a good thing. That's a very good thing. It is not MassUp, okay? With MassUp, what we're hoping to do is build upon those very, very commendable efforts, but to really move through middle or to upstream, where we can look at the underlying causes of poor health and the systemic changes that are going to have to happen in order to address issues of health equity and to ensure that every citizen in the Commonwealth has the opportunity to have good health. So when we think about both a shift in focus, we're also thinking about a shift in the sort of activities that these partnerships might undertake together to really authentically engage with the community to understand their needs, to look at what each individual component of these partnerships might be doing and align them, and ultimately to develop upstream-oriented interventions that, again, can start getting underneath the root causes of poor health and inequity. So how does all that good thinking and motivation translate into a request for proposal? Over the past several weeks, ourselves and with our colleagues at the DPH and elsewhere, we've been developing the specific requirements of the funding opportunity. There are a lot of words here, and we don't have a lot of time, so I'm going to go quickly. First and foremost, the initiatives that the investment program has a local focus. We will be focusing at a community level, at a population level, not at a patient level. Okay, so that's a significant difference. It's important that we focus on that this local focus be backed with community level data, whether that's from a community health needs assessment or other source of information. Again, this is not a typical way that health delivery organizations focus patient-centered efforts. And finally, it has to be backed with what we refer to again and again as authentic community engagement. And there are a lot of different ways that can happen. But if you're going to engage with communities, it's really helpful to actually hear directly from the people who live, work, play in those communities. The second sort of theme of requirements is really, again, about this notion of an upstream vision. We are open to new programs or building upon existing ones so long as the focus is upstream. The work has to be goal-oriented. I mean, we'll apply the same rigor that we apply to other investment programs in that we will ask people to be clear about what they're trying to accomplish and how they'll measure it. And again, it'll be a key feature of the program to be thinking from the beginning about sustainability. And then in terms of the partnership and the specifics of it, we are expecting at least one healthcare delivery organization and community-based organization to come together. If there are more, that's wonderful, but this can't be an opportunity that is directed exclusively one way or the other. Because of that, and because we understand that in the existing system, some actors tend to have more resources and influence than others, we're very interested in equitable and inclusive governance. This is really envisioned as a collaboration among equals, not one where one party gets to dictate to the others what they're going to do. And that we're really interested in clear roles and alignment among the stakeholders in these partnerships. So let me stop there and ask for any thoughts or input.
Robert Wood Johnson did an effort a lot like this called Aligning Forces a number of years ago. Mass Health Quality Partners was the lead in this area. Have you taken a look at the work that they've done to see, I think they did outstanding work, and I think the opportunity is there for this as well, but also what was it that kept it from really continuing?
Yeah, that's a really good question. And as part of this effort, we have done a lot of sort of information gathering, looking at initiatives not only in Massachusetts, but around the country to try to, build some of those lessons into our own design. I'll be honest with you, we haven't specifically looked at what didn't work and what were negative effects on sustainability, and I think that's really good advice. Other thoughts? Yeah.
Just, picking up on this, the Aligning Forces for Health framework was actually taken up with substantial investments in certain communities around the country, and those have sustained, where people really decided to use it as a transformation framework, and it might be worth looking at some of those.
Yeah. One of the things we've looked at, for example, are build health communities. What are some of the other ones, Catherine, that we?
There's a collaborative led by NEMORS, the Moving Healthcare Upstream work. We've looked at work that's been supported through the Democracy Collaborative around anchor institution strategies and some of those efforts. There are a number of really interesting models, and I think some of the takeaways from our research are really, one of the things for me anyways, that the starting point for this stuff is really individualized. I mean, some communities and systems come together around these issues as an anchor institution. Some, are identifying a particular, community level need that then sort of bubbles up through in a more grassroots way. So I think we came out of our research feeling like, number one, we're kind of onto something. There's something here that's really worth doing. And number two, that one of the things that we really need to think about in structuring this investment opportunity is to balance what we know or what we think works with flexibility. And I think people will see that, both kind of in the way we structured our RFI, looking for a lot of open-ended information and trying to get a sense of the landscape. But even as we move toward thinking about actually, putting out this investment opportunity, it's something that we've thought a lot about internally. How do we put people in the right direction? How do we hold people accountable as we need to do? But also create opportunities that honor. That people will come to this, organizations will come to this with different strengths, different interests, and different ways of collaborating, different strengths to bring together different challenges and wanting to leave room to support whatever a partnership is going to need to move itself one step upstream.
I just wanted to commend you and thank you for that second bullet under partnership. I think even when you have the most well-intentioned, great partnership, but there's an inherent difference in size, the power inherently is different. So I just want to acknowledge and appreciate that, because I think even in the best intentioned relationships, that can be hard. So thank you.
We heard that was a theme that came up again and again in our research. So in the last 3 or 4 minutes we have here, let me quickly talk about the RFI. We put out an RFI at the end of October. We were delighted to see that we got almost 50 responses. It was particularly valuable for us that we saw a lot of responses that are sort of not our usual suspects, for want of a better term. What we learned was helpful in that some of it very much validated things that we were already thinking, themes around equitable governance, the value of a backbone organization. We heard again and again that to make these partnerships go, somebody has to get up every day and be worrying about it, not doing it on the margins of an otherwise busy job. Really important themes around the value of partnership. One of the things that we did ask about was whether we should be thinking about incubating or accelerating. And I think, there was a lot of feedback from these organizations that there's enough good work going on. We don't have to generally feel like we're going to start from a blank slate, that we can build on existing work. The final theme that Catherine just echoed, and I'd, in the remaining minutes, love to hear your thoughts on, is again, this desire for flexibility. I think we are getting comfortable with, and I think the potential applicants know, this is a little bit, we're going to have to kind of wait and see what we want to do and what resources we have, and be a little bit more inclined to be flexible than we are, typically in terms of our investment programs. And we're really excited about that too, because I think we're going to learn a lot from it, and we're really looking forward to sharing what we learn more broadly. So in our last minute or so, we're happy to take thoughts or take thoughts offline.
So maybe this is a broader question, but I'm just curious in terms of where a program or looking at these challenges might lead in terms of the HPC. Do you see over time the HPC either incorporating these community-based organizations or other stakeholders in other functions of the HPC, such as this advisory council or its regulatory functions or its other research functions, to sort of more broadly expand your remit in terms of health policy?
I would say not necessarily in a regulatory sense, but I do think this is a great opportunity for us to be able to kind of expand the universe and the environment of organizations that we're connecting with, learning from, and being able to help influence policy that is going to be able, at a statewide level, to be able to help these organizations succeed and these relationships be able to thrive. The investment program, as Kelly said, is one part of this, but there's also a real commitment across all these state agencies to think about the broader policy environment we come from a very kind of healthcare provider and health market expertise level. That's why we're partnering this and doing this in equal partnership with the Department of Public Health, who knows much more about kind of community health initiatives. And so, again, we're kind of thinking, even at a government level, how do we create those types of partnerships and relationships that are going to be able to create an environment and a policy environment to be able to support great change. So I think it's actually, there's kind of two levels of collaboration that we envision learning from. If you or your organizations are interested in this, encourage you to stay connected to us as we move forward with requests for proposals before the end of the year. We'll close with another vote of thank you for participating on the Advisory Council. This is a really crucial part of the Health Policy Commission, the way we do our work. And it's been a great 2019. You have your calendar in your folders. We've already set the dates for next year, so please mark off your calendars, hold this time, and have a great Thanksgiving and holiday season. So thank you, everyone.